members and participants who have joined from various parts of India and abroad. Welcome to this webinar. I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our guest speaker, Dr. Nicola Conran, all discussants and participants to this virtual symposium on emerging pharmacotherapeutics approaches for the management of sickle cell disease. Before we commence the proceedings, I would like to welcome and introduce the host and the convener for this webinar under the aegis of Mumbai Hematology Group, Dr. Amit Khurana. Dr. Amit Khurana is a passionate and dynamic hematologist and bone marrow transplant physician from Surat in Gujarat. I request Dr. Amit Khurana to navigate this program further. Sir, over to you.
Thank you, Mr. Sumit. Very good evening to all of you, and good morning to good afternoon to those people joining from rest of the world. Today, our guest speaker for the day is Dr. Nicola Conran from Brazil. She is going to lecture us today on emerging pharmacotherapeutic approaches for the management of sickle cell disease. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan and Team Zydus, Mr. Yash, Mr. Kalpesh and the Team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. Nicola Conran from Brazil, all our discussants who are themselves eminent clinical hematologists, pediatric and adults, and you participants for sparing your Saturday evening, morning, and afternoon. Let me introduce the discussants for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Amit Jain, Thalassemia Care Center, Pediatric Hematology Oncology in BMT Center, Mumbai. Dr. Arpita Gupta from LTMG Hospital, Sion, Mumbai. Dr. Ashutosh Panigrahi from AIIMS, Bhubaneswar. Dr. Dipanjan Haldar from Jupiter Hospital, Thane, Mumbai. Dr. Dipti Jain from Government Medical College, Nagpur. Dr. Hamza Yusuf Dalal from Fortis Hospital, Mulund, Mumbai. Dr. Nishad Dakate from HCG NC HRI Cancer Center, Nagpur. Dr. Priyanka Samal from IMS and Some Hospital, Bhubaneswar. Dr. Radhika KK from Nizam's Institute of Medical Sciences, Hyderabad. Dr. Ritika Khurana from BJ Wadia Hospital for Children, Parel, Mumbai. Dr. Shubh Prakash Sanyal from Fortis Group of Hospital, Mumbai. Dr. Vikas Goel from Sanjeevan CBCC USA Cancer Center, Raipur, Chhattisgarh. Now it's a time to introduce our guest speaker for the day, Dr. Nicola Conran from Brazil. Dr. Nicola Conran is PhD in biochemistry from University of Nottingham, UK. She is a researcher at the University of Campinas, Sao Paulo, Brazil. She heads the vascular inflammation laboratory. Her research has focused on leukocyte biology and sickle cell disease pathophysiology. She has particular interest in understanding the inflammatory mechanisms that underlie sickle cell disease and the hemolytic and vaso-occlusive processes that are associated with this disorder. Besides identifying the potential molecular therapeutic targets for sickle cell disease, her group is also involved in testing novel therapeutics in vivo and in vitro. She is going to lecture us today on emerging pharmacotherapeutic approaches for the management of sickle cell disease. Over to you, ma'am. Thank you so much.
Okay, so thank you very much for the introduction, and I'm going to try and share my screen here. Okay, can everyone see that and hear me?
Just make it, ma'am, full mode, please.
Is it not full yet?
Yeah, not yet full.
Oh, it is here on my screen. Let me try again. And now?
No, not yet, ma'am.
I'll wait a little bit because it's full on my screen at the moment.
1 second, if you can try, ma'am. Once you can stop sharing and again.
Okay.
Yeah.
Dr. Nicola, are you using the two screens?
No.
Or is it?
You can see the lecture now. Is that right? I'm
Yeah.
sharing.
Yeah, we can see that.
And is it on full now?
Not yet, ma'am.
Mm.
Should be.
Okay, I'm not sure.
Yeah. One second.
Okay, I'm seeing it on full. So okay. So let me just put my timer on. So, of course, good evening to you. It's morning here, but it's evening there. So thanks everyone for giving up their Saturday evening to take part in the webinar. And I'd like to thank the Mumbai Hematology Group and Dr. Agarwal for inviting me today to talk about emerging therapeutic approaches and also biological approaches for the management of sickle cell disease. So I know that this is a really specialized audience, but I'd like to remind you of the complexity of sickle cell disease, pathophysiology, and how this affects the therapeutics that are available for the disease. Of course, sickle cell disease is caused by a point mutation in the beta globin gene, and this causes the production of an abnormal hemoglobin S inside the red blood cells. And when deoxygenated hemoglobin S will polymerize, form fibers in the erythrocytes, this will make the erythrocytes less deformable and more prone to sickling. So these alterations in the red blood cells lead to their rupture in the vasculature, eventually cause chronic inflammation, endothelial activation, and alterations in circulating red blood cells and other red blood cell types. And in the long term, all of this vascular alterations will lead to eventual widespread organ damage that's now often seen in patients as they're aging. So the manifestations and complications of sickle cell disease are numerous and extremely diverse and can be divided into acute and chronic complications. Acute complications include anemia due to hemolysis, stroke, and the characteristic painful vaso-occlusive episodes that often lead to the hospitalization of the patient. And chronic complications can include pulmonary hypertension, hepatic complications, and kidney disease, amongst others. So sickle cell disease affects about 300 to 400 newborns around the world every year, as you all know. And the vast majority of these babies are born in sub-Saharan Africa, where the mutation started. In Brazil, there's an estimated to be about 30 to 50,000 individuals with sickle cell disease. And as you know, the management of sickle cell disease is challenging, especially in low resource settings where there may be poor access to care and to drugs, even to drugs such as hydroxyurea. And in some areas, transfusions may be less safe. So in terms of morbidity, as you know, sickle cell disease is extremely heterogeneous in severity, and most patients have a reduced quality of life due to the numerous acute and chronic complications of the disease. And the disease still, unfortunately, has a very high mortality. The median age at death in Brazil was recently estimated to be about 30 years, and it's estimated to be between about 42 to 48 years in the USA. And as you know, many patients die before they're 20 years old, and the high maternal mortality of the disease is particularly worrying because this continues. Increased survival, though, survival has improved, though, in sickle cell disease, and this is particularly due to the more frequent use of penicillin prophylaxis in infancy and due to the use of hydroxyurea therapy. Increased survival brings new challenges as end organ damage becomes more frequent as patients age. So the current therapies for sickle cell disease include hydroxyurea, which is the current standard of care for sickle cell disease in most parts of the world. And we'll be talking more about this drug later. There are newer disease-modifying therapies such as crizanlizumab and voxelotor that have been approved for use since 2019. And transfusion therapy is especially used in those at risk of stroke. And there are also curative therapies such as hematopoietic stem cell transplantation and the gene therapies and gene editing therapies that are in development at the moment. So with regard to what we know at this time about the pathophysiological mechanisms that lead to vaso-occlusion, sickle cell pathophysiology is of course caused by the initial alteration in the hemoglobin molecule and red cell sickling under conditions of deoxygenation. But consequent hemolysis in turn, when it occurs intravascularly, leads to a reduction in nitric oxide levels in the vasculature and the generation of oxidative stress. In turn, inflammatory processes trigger pancellular activation, which in turn induces the expression of adhesion molecules on the surface of the endothelium, on the surface of leukocytes, on the surface of platelets, and also on red blood cells. So all of these cells form heterocellular aggregates due to this activation, and there is adhesion of the cells to the endothelial wall. So especially in the microcirculation where the blood vessels are small, the cellular adhesion reduces blood flow in the blood vessel. And this physical reduction in blood flow will lead to reduced cellular oxygenation in the vessel and increase red blood cell sickling in the vessel. These sickled red blood cells will then become trapped among these cellular agglomerates, and we can eventually see on occasions the occlusion of the blood vessel and the impeding of blood flow going through this blood vessel. So inflammatory mechanisms drive and propagate vaso-occlusive processes in sickle cell disease, and many of the emerging therapeutic approaches in fact aim to reduce this inflammation. So in my view, there are three major sources of inflammation in sickle cell disease. First of all, we have alterations in the red blood cells themselves and their membranes, and their release of microparticles, which can cause oxidative stress, interfere with adhesive interactions, and induce inflammatory responses. These red blood cells are very fragile, and due to splenic dysfunction, this hemolysis often occurs more intravascularly. Self-free hemoglobin, once it's released from the red blood cell, will scavenge nitric oxide in the vasculature, and this nitric oxide has an important anti-inflammatory effects. Also, the release of free heme from the hemoglobin molecule will trigger innate immune responses. Pancellular activation leads to vascular occlusion, and these processes of ischemia followed by reperfusion when the blood flow is restored to the vasculature. These processes of ischemia and reperfusion are in fact inflammatory themselves. They cause further oxidative stress and the release of more inflammatory damps. So finally, splenic dysfunction itself contributes to inflammation by augmenting susceptibility to infections in patients, and increased intestinal permeability in sickle cell disease due to intestinal damage leads to translocation of bacteria from the gut into the circulation, and this causes further stimulation of innate immune pathways. And this altered intestinal permeability is now recognized as a therapeutic target in sickle cell disease. So we know that inflammatory processes drive the vaso-occlusive processes that characterize sickle cell disease and cause painful crises in patients. They also participate in the end organ damage that is very worrying in patients as they age. There are direct roles for inflammatory mechanisms in pulmonary hypertension, stroke, and acute chest syndrome, which are all very severe complications of sickle cell disease. And new data indicate a role for inflammatory processes in the hyperalgesia in sickle cell disease, and therefore in the chronic pain that many patients experience. So I'd just like to quickly touch on the research that we do at the Hematology Center at Unicamp Campinas, Brazil. We've been studying the pathophysiology of sickle cell disease for some time now. We do a lot of in vitro work where we look at cellular aspects of blood cells from patients with sickle cell disease. And we also do in vivo work where we try to help to identify novel therapeutic targets in the disease. So we have a colony of Berkeley transgenic sickle cell mice at Unicamp. And more recently, we acquired and started up a colony of the Towns mice at the university. So we use these mice in a lot of in vivo protocols, particularly for doing vascular monitoring. One technique that we use a lot is intravital microscopy. For this technique, we expose the cremaster muscle of the mouse when it's anesthetized, and we stretch this cremaster muscle over a microscopic platform. And this allows us to visualize the venules of the microcirculation of the cremaster muscle using either conventional or confocal microscopy. We usually use induce the vaso-occlusive processes in the microcirculation by injecting an inflammatory molecule. We often use TNF-alpha cytokine as an inflammatory stimulus, and we inject this TNF about 3 hours before using microscopy to look at the venules. So when we look at a venule in the cremaster circulation, after the TNF-alpha has been administered, we see vaso-occlusive-like processes in these venules. So you see here a venule of a mouse with sickle cell disease after TNF injection, and you can see here leukocytes adhering and rolling along the vascular wall. You can also see blood cells flowing through the blood vessel, and you can see on occasion sickled red blood cells. So the fact that we're seeing these blood cells and red blood cells going through the vessel means that this blood flow has slowed. It's slower due to this inflammatory process, which is causing vaso-occlusive-like processes. Here, using conventional microscopy, we can look at the adhesion and recruitment of leukocytes to the blood vessel wall, and also look at the blood flow in these vessels. Using confocal microscopy, we can label different cell types to look at how they interact with each other. And in this video, we have been looking at labeled neutrophils and platelets and red blood cells to see how they interact with each other during the vaso-occlusive process. So this methodology in sickle cell disease mice was developed originally by Paul Frenette's lab in New York, by the late Paul Frenette. We were very lucky to be able to send a student to his lab some time ago who learned this method, took part in what was going on in the lab, and was able to bring this methodology back to our lab as well. So we're very grateful for that. In addition, we use these mice for a lot of other techniques. We can isolate the animal's organs after their euthanasia to look at proteins expression in the liver, kidney, and brain, for example. We can look at collagen deposition and organ histology in these organs. So getting back to the therapeutic approaches that can prevent vaso-occlusion in sickle cell disease, there are a number of therapeutic approaches that have been developed to counter the pathophysiology of sickle cell disease. And first of all, we're going to talk about the upstream approaches, the approaches that aim to inhibit the polymerization of hemoglobin S inside the red blood cell and therefore decrease red blood cell sickling. So of course, the classic example of this kind of drug is hydroxyurea, which is known to work principally by increasing the production of fetal hemoglobin. And this, of course, interferes with the polymerization of hemoglobin S, reducing in turn red cell sickling and also hemolysis. Nowadays, of course, we have voxelotor, which is on the market in many countries for treating children and adults with sickle cell disease. Voxelotor is a small molecule that reversibly binds to hemoglobin, and this makes it increase its oxygen affinity and thereby decreasing hemoglobin polymerization and sickling. So voxelotor has been shown to promote a sustained increase in hemoglobin levels and has also been shown to reduce some markers of hemolysis. There's a trend for a reduced incidence in painful vaso-occlusive crisis frequency during 1 year of treatment in patients taking voxelotor. But like other new novel therapies in sickle cell disease, this drug is very expensive. So at the moment, there are phase 1 trials undergoing for GBT601, and this is a next generation therapy. And it's been shown that this new molecule may hold potential for even better clinical results by achieving higher hemoglobin levels and occupancy at a lower dose. Other drugs that are in development at the moment for reducing red cell sickling in sickle cell disease, and these include the erythrocyte pyruvic kinase activators. So in red blood cells, pyruvic kinase is a key enzyme in the final step of glycolysis, and activation of the erythrocyte pyruvic kinase increases ATP levels in the cells and lowers levels of 2,3-DPG. This leads to a reduction in red cell sickling in vivo, increases hemoglobin levels, and ameliorates red blood cell deformability as a whole. So mitapivat and etapivat are at the moment in phase 2-3 trials for treating sickle cell disease. So with regard to the pathophysiological mechanisms that are downstream from red blood cell sickling, there are a number of therapeutic approaches that have been or are being developed at the moment to counter these mechanisms. In particular, of interest are agents that counter hemolysis and also oxidative stress, and drugs that replace nitric oxide in the vasculature and augment signaling of the nitric oxide second messenger cyclic GMP have been widely investigated in recent years. Of course, there are biological agents that neutralize the cytokines and adhesion molecules that are affected by sickle cell disease. And another approach that has been tested in the past is to inhibit platelet activation. But unfortunately, this class of drugs has not been shown to found to show efficacy in sickle cell clinical trials to date. Probably we're going to see the use of, in the future, proteins that bind to and clear cell-free hemoglobin and cell-free heme, thereby preventing inflammatory events that are caused by heme. And there's an ongoing phase 1 multi-center clinical trial at the moment that's sponsored by CSL Behring. And this trial aims to evaluate the safety, tolerability, and pharmacokinetics of plasma-derived hemopexin in adult patients with sickle cell disease. The L-glutamine supplement is an antioxidant that was approved for use in sickle cell disease by the FDA in 2017. It's marketed as Indari. L-glutamine improves the redox state of red blood cells and thereby is thought to reduce crisis frequency in patients. Anti-inflammatory NRF2 activators such as IMR261 are also under study for sickle cell disease. And one approach that I think should be more thoroughly investigated based on the importance that intestinal permeability has shown in non-sterile innate immunity responses in sickle cell disease is the use of antibiotics in adults for depleting the microbiota in patients. Preclinical trials and pilot studies have shown that the administration of antibiotics to patients with sickle cell disease and to animals with sickle cell disease can lead to a reduction in neutrophil activation, improvement in inflammatory parameters that are related to organ damage, and there have been shown to be some clinically relevant improvements in patients with sickle cell disease taking antibiotics. And of course, there are other drugs that have been developed specifically to decrease the recruitment and adhesion of leukocytes, red blood cells, and platelets to the vascular wall in sickle cell disease. And the most well-known of this class of drugs, of course, is crizanlizumab, which has been approved by many of the regulatory agents around the world for use in sickle cell disease. So crisanolib is an antibody that works by inhibiting the adhesion, the interaction of the P-selecting molecule with its ligand on leukocytes, particularly, and P-selecting is expressed on activated endothelial cells and also on activated platelets. So when you use the crisanolib molecule, this prevents the adhesion of platelets in particular to leukocytes, but also the adhesion of leukocytes to the endothelium in interactions mediated by P-selecting. And this will reduce the formation of heterocellular aggregates and also the adhesion of leukocytes to the blood vessel wall. There has, however, been data from a recent STAND phase 3 trial that found that has been shown that crisanolib has little evidence that it improved annualized rates of vaso-occlusive crisis in patients, but data are being compiled to see to revisit the point. And there is also a new antibody called inclacumab that specifically binds P-selecting, binding to PSGL1, an adhesion molecule found on leukocytes and endothelial cells. And this antibody appears to demonstrate a robust and durable inhibition of adhesive interruptions between platelets and leukocytes. Inclacumab is currently in phase 3 trials for sickle cell disease. And the role of the inflammasome in the generation of inflammation in sickle cell disease has been causing a lot of interest recently. And this is due to the importance of the inflammasome as a therapeutic target. So the inflammasome represents an intracellular multiprotein complex, which is formed mainly in immune cells, particularly macrophages. And this inflammasome complex drives the processing of cytokines interleukin-1 beta and interleukin-18 into their mature and active forms. So some of the inflammatory molecules that we're looking at at the moment in our lab are the inflammasome process cytokines, interleukin-1 beta and interleukin-18. There is evidence to indicate that the hemolytic process may induce inflammasome formation, particularly in macrophages in sickle cell disease, but possibly also in platelets, endothelial cells, and leukocytes. And in this manner, hemolysis seems to upregulate the processing of interleukin-1 beta and interleukin-18. And indeed, in our population of patients at the Hematology Centre in Unicamp, we have found that plasma levels of interleukin-1 beta and interleukin-18, which are the cytokines processed by the inflammasome, are significantly elevated in the plasma of patients. And other scientists, other researchers have found similar things, similar results in other populations of sickle cell disease patients. So in a recently randomized, double-blind, multi-center phase 2 study by David Rees and colleagues, children were given monthly subcutaneous administrations of canakinumab, which is an interleukin-1 beta blocking agent, and these treatments were given monthly for 6 months in patients. So although there were no significant reductions in pain that were observed in the treated group, some inflammatory molecules were found to be improved and reduced by the treatment, and other parameters such as fatigue showed amelioration in the patients. So knowing that the inflammasome is an important therapeutic target in inflammatory diseases, we started to look at interleukin-1 beta and interleukin-18 blockade in our animal models of sickle cell disease. And for this, we used that intravital microscopy technique that I showed you before, whereby we look at the microcirculation of the cremaster muscle of the animals with sickle cell disease, and we induce vasocclusion in these venules by giving the mice TNF-alpha 3 hours before looking at the venules of these mice. So you see here a mouse that received TNF-alpha, and you see again, as we saw before, a venule of this mice where there are leukocytes rolling along the blood vessel wall and a very extensive adhesion of the leukocytes to the blood vessel wall, which slows down the blood flow. You can see that this blood flow is slower in this mouse that's taken TNF-alpha. We can quantify the adhesion of the leukocytes to the blood vessel wall. You see that in this graph with this high adhesion of leukocytes in the mice that received just TNF-alpha. Antibody that neutralizes the activity of interleukin-1 beta or interleukin 18 a day before inducing this vasocclusion, you can almost completely abolish this recruitment and adhesion of the leukocytes to the blood vessel wall. So you see here in the mouse that took interleukin-1 beta, you can hardly see any leukocytes. You can see one leukocyte, one or two leukocytes rolling along the blood vessel wall. And the blood flow is really considerably improved by giving this antibody. The same thing we see in mice that received interleukin 18, the antibody that neutralizes interleukin 18. And in fact, this antibody seems to work even better in the mice that take these treatments. When we gave both of the treatments together, anti-interleukin-1 beta and anti-interleukin 18, we didn't see any additive improvement in the use of these antibodies. So these data provide further evidence that both interleukin-1 beta blockade and interleukin 18 cytokine blockade could be useful for preventing vasocclusion in sickle cell disease, and that we should be insisting on looking at the use of these biological agents in the disease. There are some interleukin 18 blocking agents that are in clinical development at the moment for inflammatory diseases in general. So carrying on from this project, we developed a project together with Novartis in which we used antibodies that neutralize either interleukin-1 beta or interleukin 18. But this time we used these antibodies together with an antibody that blocks the binding of p-selectin, much as crizanlizumab does in patients taking the p-selectin inhibitor. So here, in this first video, again, we used intravital microscopy. We see that in contrast to when we used the anti-interleukin-1 beta and anti-interleukin 18 agents, when we block p-selectin, we don't actually see much of a difference or reduction in the adhesion of leukocytes to the blood vessel wall after we've induced vasocclusion in these mice with TNF-alpha. But we do see a very big significant decrease in the rolling of the leukocytes along the blood vessel wall. So the leukocyte, to adhere to the blood vessel wall, it has to roll along the blood vessel wall before it can firmly adhere. So it wasn't much of a surprise that we saw this decrease in the rolling of these leukocytes, because in fact, p-selectin is involved in the rolling of leukocytes. But what was a slight surprise was that even though we inhibited this rolling, we didn't see much of a change in the adhesion of these leukocytes. So we use this antibody together with the approaches that inhibit the activity of interleukin-1 beta and interleukin 18. Again, if you look at the adhesion of neutrophils in mice that had received just anti-interleukin-1 beta and just anti-interleukin 18, we see this really evident decrease in adhesion in the venules, in leukocytes to the venules of mice. And we also see a slight decrease in the rolling of these cells along the blood vessel wall. But when we use the anti-p-selecting antibody together with these two approaches, we managed to potentiate the effects of both in neutralizing interleukin-1 beta and interleukin 18. So we're collecting data at the moment that indicate the effects of crizanlizumab could be potentiated by concurrently administering agents that also neutralize the effects of inflammasome-derived cytokines. So moving on from the biological agents that are in study at the moment, there are a whole class of pharmacological agents that increase nitric oxide dependent signaling and also amplify and increase intracellular levels of cyclic GMP, which is the second messenger for nitric oxide. So these are drugs that work on this effect of hemolysis in reducing nitric oxide bioavailability in the vasculature. And we're going to see later on that hydroxyurea exerts many of its effects, in fact, by activating this pathway. So just to remember, cyclic GMP is a cyclic nucleotide, which is the intracellular second messenger for nitric oxide. So if we consume nitric oxide in the vasculature due to hemolysis, we're going to end up reducing intracellular levels of cyclic GMP. Cyclic GMP in the smooth muscle cells is important for vasodilation, but we also know that if we can augment cyclic GMP levels in erythroid cells, we can also induce the production or the generation of gamma globin and in turn fetal hemoglobin. By increasing cyclic GMP levels in leukocytes, we actually managed to decrease their adhesive properties. So this is an important pathway as a therapeutic target. We have a pathway that can manage to increase fetal hemoglobin levels in erythroid cells, and we have a pathway that can reduce the adhesive mechanisms of leukocytes. And this is important because we're coming in from two approaches with the same signaling pathways that can ameliorate in the long term sickle cell disease and also in the short term by reducing vaso-occlusive processes. So the phosphodiesterase enzymes are intracellular enzymes that degrade the cyclic nucleotides, cyclic GMP and cyclic AMP inside cells. And inhibiting these enzymes can thereby increase intracellular levels of cyclic nucleotides. There are at least 11 subfamilies of phosphodiesterase enzymes, and all of these families have different specificities for the cyclic nucleotides that they degrade, and they are expressed in different tissue and organ types. So some time ago, we screened to identify the phosphodiesterase enzyme that was most expressed in erythroid cells and also in leukocytes of patients with sickle cell disease. And we found that PDE9 was highly expressed in both the neutrophils and in the erythroid cells of patients with sickle cell disease. We then went on to screen a whole host of cells and organs and found that PDE9 is highly expressed in hematopoietic cells and also in the brain, but showed very little expression in other tissues and organs. So this was of interest because we had a relatively tissue-specific molecular target, and drugs that inhibit PDE9 were already being developed for the treatment of Alzheimer's disease. And we did a number of assays in vitro and in vivo, which showed that inhibiting phosphodiesterase 9 could increase gamma globin production in erythroid cells and could reduce the activation of vaso-occlusive processes in mice with sickle cell disease. So on the basis of these results, Imara, the company Imara, which was formerly part of Cydan, looked for a PDE inhibitor molecule that couldn't penetrate the blood-brain barrier. So the idea of this was finding a drug that could specifically inhibit PDE9 in the hematopoietic cells, but wouldn't cross the blood-brain barrier into the brain. And this led to the development of IMR 687, which was up to very recently being used in phase 2 clinical trials for patients with sickle cell disease and thalassemia. But unfortunately, quite recently, the company discontinued the trials due to the difficulty in reaching clinical endpoints. This study also led to clinical investigations, preclinical and phase 2 trials of the use of guanylyl cyclase agonists in sickle cell disease. So if you activate the soluble guanylyl cyclase, you can also amplify cyclic GMP levels by coming in at the top of this pathway. One example of a drug that can that's an agonist of guanylyl cyclase is SIGWAT, which was used in early clinical trials fairly recently. So I'm going to move on now to talk about hydroxyurea, and in fact the idea that possibly we're not making the most of some of the benefits of hydroxyurea. So as you know, hydroxyurea is the current standard of care for preventing vaso-occlusive crisis in many centers of the world for sickle cell disease, and it ameliorates many of the complications of sickle cell disease, in particular reducing the frequency of vaso-occlusive crises and ameliorating the mortality of patients. It's a relatively inexpensive drug, which is why I think we should be trying to make the use of hydroxyurea as best we can. And it's generally believed that hydroxyurea works mainly as a cytostatic agent that has major effects on fetal hemoglobin production, which thereby reduces hemoglobin S polymerization and red cell sickling. But in fact, hydroxyurea exerts many benefits that are independent of its ability to induce fetal hemoglobin. The drug often reduces, and this has been known for a long time, hydroxyurea administration to patients with sickle cell disease reduces the number of the numbers of leukocytes in patients, and this is often seen before the increase in fetal hemoglobin. And this drug has a very important property. It can donate nitric oxide in vivo. And this nitric oxide formation occurs within just 30 minutes of giving hydroxyurea orally to patients. So based on this idea that hydroxyurea is a nitric oxide donor, we hypothesized that hydroxyurea can replace the nitric oxide that's being scavenged by cell-free hemoglobin during the hemolysis process in sickle cell disease. And by replacing this nitric oxide, we could improve vasodilution in the vasculature and also reduce inflammatory processes, because as I mentioned, nitric oxide is an anti-inflammatory molecule. So as we mentioned before, this nitric oxide cyclic GMP pathway has a role in elevating gamma globin production in erythroid cells and reducing the adhesive properties of leukocytes. And in vitro assays have been able to show that hydroxyurea can activate this pathway and do exactly this in vitro. So hydroxyurea can elevate gamma globin in erythroid cells and can decrease neutrophil, particularly adhesion, via this pathway, this cyclic GMP-dependent pathway. So knowing all of this about hydroxyurea and the evidence for its use as a nitric oxide activator, we decided to explore the acute and immediate effects of hydroxyurea in preclinical protocols, particularly in mice with sickle cell disease. So again, we used intravital microscopy to look at the vascular microcirculation of mice with sickle cell disease. Again, we induced vaso-occlusive processes in these mice with TNF-alpha, and we can see vascular inflammation with the recruitment of leukocytes to the blood vessel wall in the mice, or the venules of mice that took just TNF-alpha. However, if you give hydroxyurea orally or intravascularly to this mice just before inducing the vaso-occlusive processes in mice with sickle cell disease, you manage to almost completely abolish this inflammation. You've managed to almost completely abolish the recruitment and adhesion of the leukocytes to the blood vessel wall, and you manage to ameliorate the induction of these vaso-occlusive processes. And in other experiments, we found that the effects of hydroxyurea in this model with sickle cell disease, this ability to prevent vaso-occlusive processes in this immediate manner, were mediated by activation of the nitric oxide cyclic GMP pathway. And in other experiments, we managed to show that if you give hydroxyurea together with a cyclic GMP amplifier, In this case, we gave the mice an inhibitor of PD9. We managed to improve the survival of mice that were undergoing vasocclusion. So when you induce vasocclusion in a mouse with an inflammatory molecule such as TNF-alpha, they undergo multiple vasoclusive processes, and they do not generally survive for more than 6 hours. However, when we gave the mice hydroxyurea together with this cyclic GMP amplifier, we did manage to significantly improve the survival of these mice. We then went on to test the effects of hydroxyurea and its immediate acute effects in a murine model of intravascular hemolysis. So we developed a model of acute hemolysis in mice, just C57 mice that didn't have sickle cell disease. And in these mice, we injected a very small amount of water intravascularly, and this protocol, in fact, induces a very similar amount of hemolysis that we see in mice with sickle cell disease. And it was quite a surprise, because when we induced this hemolysis, we were able to see a very extensive systemic inflammation that was induced very rapidly within just 15 minutes in these mice after hemolysis. And we also saw the vascular inflammation in these mice with the recruitment of leukocytes to the blood, the venule walls. So we saw the systemic inflammation that was induced by hemolysis using in vivo imaging. And again, we used intravitreal microscopy to look at the vascular inflammation. However, so these are mice, normal mice that were undergoing hemolysis. If we gave hydroxyurea just once, just before we induced this hemolytic event using water, we were able to manage to completely prevent the inflammation that was caused by hemolysis. So here you saw that hydroxyurea abolished the systemic inflammation that was caused by hemolysis and was able to prevent the vascular inflammation that was caused by hemolysis. And again, we used other experiments to show that the hydroxyurea manages to prevent this inflammation that's caused by hemolysis in a mechanism that's mediated by either nitric oxide donation or activation of the cyclic GMP pathway. So we concluded that hydroxyurea has immediate nitric oxide cyclic GMP mediated benefits on inflammatory process and that as such hydroxyurea could be important or interesting because hydroxyurea could be important not just for use for combating hemolysis in sickle cell disease, but also for use for preventing inflammation in other hemolytic diseases. So with these data, we began to hypothesize that in fact hydroxyurea could be a potential approach for treating patients that were already in vaso-occlusive processes. So as you know, there are no therapeutic approaches at the moment for treating patients that are hospitalized with painful vaso-occlusive crisis. At the moment, current patients receive management that consists of hydration and pain medication, but there's no drug available that specifically reduces vaso-occlusive processes once they're installed. So on the basis of all this preclinical evidence we designed a very small pilot clinical trial to start investigating hydroxyurea as a drug that could potentially be used in patients that were hospitalized for vaso-occlusive crisis. The HELP study was designed as a single center randomized open label intervention phase 2 study, and it aimed to evaluate the safety and efficacy of the administration of up to between 1 and 3 moderate to high doses of hydroxyurea after the onset of vaso-occlusive crisis in sickle cell disease. And this study was carried out in collaboration with the Hemo Center in Rio de Janeiro, Brazil. So all the patients that were included in this study were attended at the Hemo Center. Sickle cell disease patients, when they arrive at the emergency room in the center in pain, are triaged in the center, and all patients undergo complete blood cell counts and a physical examination. And once patients had been confirmed to be in vaso-occlusive crisis, they were evaluated with regard to the inclusion and exclusion criteria of the study. So to be included in the study, patients had to have arrived at the ER within the last 8 hours. They had to have had a pain score of at least 6 within the last 24 hours and a pain score of at least 4 at the time of inclusion in the study. And patients should not have been presenting neutropenia at the time of inclusion, amongst other exclusion criteria. So 30 patients fulfilling the criteria were invited to take part in the study. Half of these patients were randomized to the non-intervention arm, where patients received the center's standard of care, which consisted of pain medication and hydration. And the other half of the group were randomized into the intervention arm. These patients received the same standard of care, but they also received between 30 to 45 milligrams per kilo of hydroxyurea immediately upon their inclusion in the study. And then if patients were still hospitalized, they received up to 2 more doses of hydroxyurea every 24 hours. So while patients were hospitalized, we recorded various events during their hospitalization. They were evaluated for pain, blood counts, pain medication, adverse events, and transaminases were recorded, as well as the length of stay. And also patients were invited back to attend a post vaso-occlusive crisis consultation at 7 days after discharge. Primary outcomes that we wanted to evaluate were the safety of giving hydroxyurea at a moderate dose during crisis, especially in those patients that had never taken the drug before. And as secondary outcomes, we wanted to look at the efficacy, although we knew that there were a very small number of patients taking part in this trial to look at this. 27 patients concluded the study, and the mean dose of hydroxyurea that was administered was about 30 milligrams per kilo per day in the patients. So with regard to safety data, mild to moderate adverse events did occur in both the control non-intervention group and in the group that received hydroxyurea, but they were very similar and consisted of nausea and vomiting, and to the same extent and the same frequency in both groups. There was one serious adverse event, which was the sad death of a patient due to sepsis at 48 hours after inclusion in the study, and this occurred in the non-intervention arm. Of interest, we did find some differences in blood counts in patients that underwent the study. We found at the post-crisis consultation a very small but significant increase in red blood cell counts in the patients that had been taking hydroxyurea, and this wasn't seen in the patients that weren't taking hydroxyurea. And at the same time, we did see a very small drop in reticulocyte numbers in the same patients taking hydroxyurea that wasn't seen in the patients that weren't taking hydroxyurea. So it's possible that giving hydroxyurea during crisis does improve some aspects of it does improve anemia in these patients. In addition, we found that leukocytes counts were very slightly but significantly reduced in the patients that had been taking hydroxyurea at 7 days after discharge, and this again wasn't seen in the patients that weren't taking hydroxyurea. With regard to length of stay and pain scores, there were slightly but not significantly slight decreases in the length of stay and the pain scores in the patients taking hydroxyurea, but this wasn't significant, and obviously we would need a much larger population to look at the efficacy of giving hydroxyurea on pain in hospitalized patients. So basically, in preclinical studies, we found that hydroxyurea has immediate and acute benefits. Its administration can prevent cytokine-induced vaso-occlusion in sickle cell mice, and this is mediated by activation of the nitric oxide cyclic GMP signaling pathway. Also, hydroxyurea can prevent the inflammation that's caused by the inflammation that's caused by hemolysis. And from our clinical study, we concluded that it appears to be at least safe to administer hydroxyurea when a patient is hospitalized for vaso-occlusive crisis, and that hydroxyurea for those patients that regularly take hydroxyurea should not be withheld during hospitalization. And this is a very small pilot study, but it would be of interest, of course, to conduct a multi-center study with dose scaling to further investigate the benefits of administering hydroxyurea during crisis in patients with sickle cell disease. So I'd just like to conclude the talk by highlighting the fact that it's essential that we continue to study and understand the pathophysiological mechanisms of sickle cell disease. And this is so that we can identify novel therapeutic targets downstream from hemoglobin F polymerization, and also to identify new inflammatory biomarkers to look to use in clinical trials, and to look at the effects of monitoring new therapeutic approaches for sickle cell disease. I'd like to just thank everyone for listening today. I'd like to thank my team at the Vascular Inflammation Laboratory, past and present, also the clinical team at the Hematology Center in Unicamp, and my collaborators at the HemoHio, the Albert Einstein College of Medicine, and in other centers. So thank you very much for listening, and I'll take any questions.
Thank you so much for a wonderful talk and important new insights in the treatment and management of sickle cell disease. So we have some Indian colleagues. We can start our discussions and question answer sessions with our Indian colleagues. Ma'am, do you want to take a break, or should we start, ma'am? Sure. Okay, so we will start with the raising signs with.
She's muted. Dr. Nicola, you're muted.
Yeah, I'm just waiting for.
I request all our discussions to please give the raising signs so that we can start our questions now. So, ma'am, let me ask one question to you till the questions do come. So, what's the role of L-glutamine therapy in the treatment of sickle cell disease during crisis?
Okay, so there hasn't been a lot of data about its use since it's started coming out, being used in sickle cell disease. I think there are so many options now for new therapies in sickle cell disease. I know that when we use L-glutamine in mice with sickle cell disease, we do see some improvements in inflammatory parameters in these mice. So I'm talking in terms of preclinical protocols. When we give L-glutamine, we can improve some aspects of the inflammation that's caused by hemolysis in these mice.
So does it really work, ma'am?
We're not giving the Endari here at our center, so I don't have any news about what's going on. What's your experience with it in your center?
I think it works.
In theory, it should work.
True. One more question I have, ma'am. That what is the management of sickle cell disease who have developed allo antibodies? So that means management of red cell elimination in sickle cell disease patients.
Sorry, I was distracted by a message that came up. So you wanted to know about the use of antibodies in sickle cell disease and
antibodies, allo antibodies. So management of red cell allo immunization.
Oh, okay. So I'm really sorry. That really isn't my my subject. But obviously, inflammation is a really important aspect of the production of alloantibodies in sickle cell disease, and that's something that it's really important to study. It's not in my field, but I know that everybody's very interested in understanding how inflammation affects the production of alloantibodies in sickle cell disease.
One question from Dr. Priyanka Samal. Priyanka Samal, you can ask a question directly.
Yeah, that was a very nice presentation, ma'am. Thank you. So I have two questions. Yes, ma'am. So during crisis in India, we find some of the patients having splenomegaly and then sequestration crisis. So how would you suggest the dose of the hydroxyurea would be to prevent that, to be administered during that crisis?
Okay, so use of hydroxyurea in a patient that's undergoing splenic sequestration.
Yeah, the patient is in VOC. Yeah. There is sudden enlargement of the spleen. We find there is hepatosplenomegaly. there is a sudden
Mhm.
drop in the counts also. The TLC goes down, the platelets go down. So you showed that there is a very good anti-inflammatory action of the hydroxyurea during that time. So how would you administer what will be the dosage of hydroxyurea in these patients?
Well, in theory, the hydroxyurea should work via the donation of nitric oxide in this case. It should reduce inflammatory processes. I'm not sure, obviously, and nobody has ever tried to do this specifically during the splenic this event. But it sounds like something that hydroxyurea could be used to reduce inflammation in this patient. What do you think?
Madam, we have used it in, suppose when the crisis, actually they do not present with a single crisis. It is usually multiple organs are affected, and at that point of time, we have used it in alternate doses, like 500 mg alternate. We have capsules, so we use it as 500 mg alternate days. And ma'am, there is another question, like hydroxyurea, if we go to a higher dose, if it is 20 or 25 milligram per kg, how would you like to distribute the dosage? Like it will be TDS, or you would like to go with a single dosage once daily?
Okay, so this is a good point. Obviously, if hydroxyurea is releasing nitric oxide very rapidly, it makes sense to divide the doses during the day if that's possible. But obviously, this is not something that's clinically proven, but it makes sense that if you divided the doses during the day, this could be more useful by giving more doses of nitric oxide during the day. It makes sense. It's a good question. Obviously, what would be really interesting would be to produce a hydroxyurea that's a slow release hydroxyurea in a nanomolecule, a nanoparticle or something. So there are so many things that you could do with hydroxyurea, and I think we should be thinking about how we could best make the most of this drug that's fairly cheap, really. So.
And last question.
Thank you.
Thank you, Dr. You have another question? Please go ahead.
Yeah, last question. So, do you have any experience of luspatercept being used in sickle beta thalassemia patients?
No, I don't. I'm afraid. I'm sorry, but that's a very interesting question.
Okay, ma'am. Thank you.
Thank you, Dr. Priyanka. Dr. Hamza Dalal, your question, please.
Thank you for the wonderful lecture, Dr. Conrad. Actually, this thing I wanted to discuss one of our patients with you. So we have a lady who has sickle cell disease, and she wishes to get pregnant. So in January 2022, we had stopped the hydroxyurea so that she could go ahead and get pregnant. But in March, before she could actually conceive, she had a acute sickling crisis. So we had to restart this hydroxyurea. At that time, she had a pulmonary embolism also. So her plan has got postponed by almost a year. So now she has been stable since a year. There have been no further crisis. So how much and how do we stop the hydroxyurea, and how much time should we wait before we allow her to conceive?
Okay, so I'm not a clinician. I think a lot of people think that perhaps there is no need to stop hydroxyurea during pregnancy, but I think this is something that there must be a lot of people here online that have a lot more experience of doing that than me, if anyone has any comments on that.
Okay, so in your experience, is it teratogenic? In your experience, is it teratogenic?
Well, this is something that's been discussed, and apparently there isn't. I mean, I think we have to look at the guidelines. And if I'm not a clinician, I'm a scientist, but in the British guidelines, if I'm correct, the British guidelines don't suggest that you don't need to withhold hydroxyurea during pregnancy, because there's not enough evidence of the teratogenicity. But I'm not sure. Maybe someone can correct me on this, because I cannot give. I don't have any experience in this or evidence of this. Does anyone have anything to comment on that?
Yeah, this is one of the gray areas actually.
Yeah, absolutely. Yeah.
All right. Okay, so what is the role of antiplatelets in the management of sickle cell disease?
Okay, so as I mentioned, that using drugs that inhibit the activation of platelets haven't been particularly successful to date. And this is a surprise because platelets take part in those heterocellular aggregates that are so important for the vaso-occlusive process. It's possible that we shouldn't be worrying so much about platelet activation, but worrying about how we stop them from sticking to other cells. In fact, I was quite surprised that the Prasugrel trial was not successful in terms of clinical data or clinical endpoints, because when we give mice, when we induce vaso-occlusion in mice with sickle cell disease, Prasugrel is the only drug that we can give after we've induced the vaso-occlusion that reverses the vaso-occlusion. And that's quite interesting because we need to find drugs that can reverse vaso-occlusion. We shouldn't just be looking for drugs that prevent vaso-occlusion. We should be looking for things that reverse vaso-occlusion. And Prasugrel, which is an inhibitor of platelet activity, does do this, at least in mice with sickle cell disease. So I think we should be looking at platelet activators. I mean, doing clinical trials in patients with sickle cell disease is really complicated, looking at those clinical endpoints, and I don't think we should be forgetting about the platelets as a therapeutic target. Yeah, I think you're right.
Okay. Thank you so much.
Thank you, Dr. Hamza. Dr. Amit Jain, your question, please.
So, ma'am, I have a very basic question. Since we are in India and there is a very high prevalence of iron deficiency, so sickle homozygous with proven iron deficiency, does iron supplementation increases the risk of crisis in them?
I do not have any data on that, but I think that's a really good question. I don't know if anyone has any comments on that here.
Fine.
It's an important clinical question. Yeah.
Because we do have many patients with iron deficiency in area.
Anyways, thank you, Dr. Amit Jain. Do you have any other question, Dr. Amit?
No, sir.
Right. Dr. Dipti Jain, your question, please.
Yeah, it's a partial answer to Dr. Amit Jain. Yes, we do get, I would say 25 to 30% of our patients with sickle cell anemia have iron deficiency in them. And we treat with very low dose and for 3 months and then assess again. But all patients don't need iron. At the same time, we also observed with the rise of hemoglobin, the painful crisis increases. That is our experience. My question is, very educative talk. I never thought we can give hydroxyurea. It will have a preclinical evidence of acute and anti-inflammatory action. My question is, giving this dose of 30 to 35 milligram per kg in acute, I'm talking about manifestation. One of the things we usually see with pain is infection. Is the presentation. So in the study, HELP study, do we have any data on rate of infection in these patients?
Yeah, that's right. We don't have this. Patients were evaluated, had a clinical evaluation. There was that one patient in the non-treated arm that went to orbit due to sepsis, but we didn't specifically look at inflammation and infection. And I think you're right. That's a good thing that's to be looking at. Of course, I'm just trying to think about hydroxyurea and how it could work in combating innate immune responses that are triggered by infection. This is one thing I'm looking at that we're looking at the moment, because I mean, obviously I'm here as a scientist and we test therapeutic approaches in preclinical models. And one of the things that we're really interested in, how different triggers such as infection and inflammation, cold, dehydration, if these different triggers of vaso-occlusion trigger vaso-occlusion and different mechanisms of vaso-occlusion. And one of the things we're looking at is viral infections and bacterial infections in the mice. And then once we manage to understand the mechanism of vaso-occlusion caused by these infections, then we can start looking at how we can prevent or treat the vaso-occlusion. And one of the things we're going to be looking at is hydroxyurea.
Thank you. Thank you.
A very good question. A very good point.
Thank you, Dr. Dipti Jain. Dr. Radhika Sethi, your question.
Thank you, Dr. Nicola, for the presentation. My question is on crizanlizumab. So crizanlizumab is a prophylactic drug used to control VOCs. Does it directly or indirectly affect the transmission dependency?
Sorry, what was the name of the drug that you mentioned?
Crizanlizumab, Ravindra.
All right.
Crizanlizumab.
Yeah, okay.
Yeah, crizanlizumab is a prophylactic drug used to control VOCs, vaso-occlusive crisis. Does it directly or indirectly have an effect on the transfusion dependency of the patient? Does it control the transfusion dependency also?
Transition from what to what?
Transfusion requirement. Blood transfusion requirement.
Sorry, the internet is cutting up a little bit. I'm not.
Here's a question, ma'am. That does crizanlizumab decrease the transfusion requirement of the patient?
Increase the transfusion requirement.
Decrease the transfusion requirement of the patient?
Decrease. I don't have any clinical evidence on this. I'm not involved in the trials of crizanlizumab. I'm not sure if anyone has any involvement in the trials of crizanlizumab. I think it's an important point. I don't remember if there were any data on transfusion requirement in the trials that came out. Has anyone seen anything on that?
I think it doesn't decrease.
Yeah, I hope so.
It doesn't decrease.
I just want to confirm, I'm a part of the trial on crizanlizumab. We are doing a phase 4 clinical trial. We have 14 patients, out of whom 2 patients are transfusion dependent, and it did not affect the transfusion dependency in any way. The transfusion dependency is the same.
Okay, that's an important point.
Yeah, I wanted to cross-check with you, like, does it have any effect on the transfusion requirement or not?
I'm not involved in the clinical trials at the moment, unfortunately, but that's important. I think it's interesting to know that. So.
Thank you. That was my question.
Thank you.
Thank you, Dr. Radhika. We have one question, ma'am, from Dr. Naresh Tayade. He wants to know that what is the dose of hydroxyurea for acute benefit of crisis?
Okay, it has to be a bit higher. So in the mice, we used a very high dose, which was, I think, 100 mg per kilogram. But it's actually high because you have to use a higher dose in mice. When we set out to do the trial, the HELPS trial, our aim was to use about 45 milligrams per kilo per patient. But it was quite difficult because of getting the dosage right due to the pills, the pill size and everything. We had a problem doing that. And our idea was to do at least 45 to 50 milligrams per kilo, because in the first trials of hydroxyurea in sickle cell disease, they were using about 50 milligrams per kilo. So when you're using as an acute approach, you don't have to worry quite so much about the neutropenia that occurs during the chronic use of hydroxyurea. You're just giving it for a small time during the crisis, and obviously you have to keep an eye on the leukocyte numbers, but the idea is that you should be able to use a slightly higher dose of hydroxyurea than is used chronically normally.
True, ma'am. Then still at a very high dose, some of the patients do not benefit with hydroxyurea. Why so? What is the reason behind it, ma'am?
Sorry.
Such a high dose of hydroxyurea, some of the patients do not benefit with that. Why some patients do get the benefit and others do not get the benefit? Right.
Yeah. I don't know. I mean, there are so many reasons why people don't respond to hydroxyurea. In theory, when you're talking about the acute benefits of hydroxyurea, there may be interference from polymorphisms of in theory, you're giving nitric oxide to the patient, and it should have more or less the same effects on the patient, but it depends on the extent of the inflammation that the patient already has. So I don't know how to respond to that specifically, but when you're talking about the acute effects of hydroxyurea, it should be similar in most patients.
Thank you, ma'am. Dr. Deep Gala has congratulated for a wonderful lecture, and he has asked a question that do you routinely use thromoprophylaxis in patients with sickle cell crisis?
Prophylaxis of
Thromoprophylaxis.
Homoprophylaxis. I'm sorry, you're going to have to explain to me. I'm not a clinician. So I don't know anything about. I don't know a lot about the management.
No issues.
So.
No issues. Another question from Dr. Raj Warrior. He has asked a question that if you document iron deficiency in hemoglobin SS, that is sickle cell disease, they should be supplemented as needed. And what is your comment on that?
It's difficult for me to comment about iron deficiency. I think probably the other hematologist here may have an opinion about that, if anyone has any comments on that.
He also commented that if you use iron at a dose of 3 milligram per kg till the hemoglobin comes to normal or a stable level, that would be benefited to the patient. If the patient has got iron deficiency in context of sickle cell disease. But another comment also he has made, Dr. Rajburi has made, that there is no role of hydroxyurea, I think, in sequestration crisis. And it's a life-threatening emergency and needs aggressive supportive care as such. So maybe I think during sequestration crisis, maybe hydroxyurea may not work. What's your comment on that?
Well, I think if there's inflammation there, it's possible that it might work. But I mean, obviously, it's something that would have to be tested at least in the mice models.
So, Dr. Hamzadallah, you have another question? Dr. Hamzadallah, do you have a question? Okay, so anybody else?
No, I don't have any. I don't have a question.
Okay, thank you. So anybody has any other question for ma'am? I finished all the questions from the chat box. Well, ma'am, in that case, what a wonderful lecture we had, and what a new insight again in the new molecules and pathophysiology, hydroxyurea and all other drugs. And thank you for a wonderful interactive question answer session. Thanks.
Thank you very much. Yeah.
Thanks for joining.
Thank you very much.
And spending your time this Saturday.
Okay. Thank you very much for you inviting me. Thank you for inviting me. And I think it's really important to have exchanges between, it's important for me to hear what hematologists think and think about the clinical aspects of sickle cell disease, and talk to people from different regions of the world. People who have different experience of managing patients with sickle cell disease. And it's really has been very interesting for me to talk to the group. So thank you very much for inviting me and for everyone to give up their Saturday evening to take part. Thank you.
Thank you so much. I now request Zydus Pharmaceuticals to please go for final vote of thanks. Mr. Sumit, you can please take over.
Thank you, Dr. Nicola Conran, for sparing your valuable time. It was a lucid presentation, and different aspects on management of sickle cell disease were covered in your presentation. And we have many key takeaways from this wonderful presentation. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal sir, for providing us this opportunity and making us a part of this esteemed academic discussion. I also thank Dr. Amit Khurana, all the discussants and participants who have joined us for this webinar. Dr. Amit Khurana navigated the entire program in a highly proficient way. Thank you, sir. And last but not the least, this series of webinars is possible only because of continuous support from Perfect Square team. So thank you to Perfect Square team. Thank you so much, everybody, and have a wonderful weekend.
Can I take a photo, if that's all right? Yeah.
Sure.
Thank you.
Thank you so much.
Thanks very much.
Thank you so much.